So Dr. Joveeta will be talking to us about microbiology, including the testing, which how they follow in assessing a case of endophthalmitis. Dr. Joveeta is doing extremely, she is head of the department at LV Prasad, Hyderabad, and doing very extensive work. Has done a lot of work on NGS, as you will see what she is presenting.
Thank you very much for the kind introduction. At the outset, I'd like to thank the organizers, especially Dr. Das, for inviting me to present what we do at LV Prasad Eye Institute in endophthalmitis. So, we all know that endophthalmitis in India is synonymous with Dr. Das, and so thank you, Dr. Das, for inviting me today to present our work. And before I begin this talk, I wanted to wish him a very happy birthday today. Coincidentally, it is his birthday. So when I Googled to know how old he turns today, this is what Wikipedia shows me. So I don't know if he was trying, if Wikipedia is wrong or he was trying to fool the world with this date of birth. But I have authentic information from his wife that today is his real date of birth. So happy, Dr. Das, whether you are 75 or not, we wish you a very young and prosperous birthday. Okay, coming back to microbiology. Unlike when I present in front of the cornea folks, presenting in front of the retina folks always makes me nervous, because microbiology, I don't know how much relevant it is in front of retina surgeons, because you all have already injected antibiotics even before we begin microbiology. So most retina surgeons are so reluctant to even wait for the cultures and feel microbiology is just procedural. Most often, I often get fellows who come and ask me why are cultures negative when they even forget to send the samples to the lab. Between the OR and the lab, the samples are often lost. And very often negative cultures are blamed on poorly collected, poorly transported, sometimes non-existent samples. That is just the gist of it. But what we have to remember in this era is, along with direct observation and clinical features, today microbiology cannot rely on just isolation and characterization of the organism. Today we have to shift to molecular evidence. And I'm keeping this puzzle like this as still open, because there are still lots of answers and lots of clues that we do not know. Even in direct observation, microscopy is advancing. Even in clinical features, there are still lots of features, as Dr. Das has mentioned, how severity score can be a clue to the organism. Even in isolation and characterization, we probably are not using anaerobic media, which could be a clue to anaerobic organism. In molecular evidence, along with PCR, along with NGS, we probably should use other techniques to isolate other fastidious organisms. So the realm is expanding, and the future still will keep growing. So I'll take you back to a paper in 1999 from our institute, where this was what we published at that point, where the spectrum of postoperative endophthalmitis of gram positive was 46%, gram negative was 26%, and fungi was around 16%. Now, when you compare this with EVS and other studies in India, it was obviously different from the EVS, but more or less in India, all of us agree that gram negative and fungal did have a substantial percentage, though in varying numbers. Some of us had higher gram negative, some of us, like PGI, had higher fungal spectrum. And all of us across the country have tried to use an array of smears and an array of media, liquid culture, an array of fungal media, bacterial media, anaerobic media, and still the percentage of culture positivity ranged from 30% to 60%. But what has changed since then? In the last 3 decades, now this was a study which we published in the last, when we compared, okay, I'm able to see it, I don't know what happened there.
It's come, come.
Okay. So what has changed in the last 3 decades? What we can see is from 1991 to 2015, the culture negativity, while the positivity which was earlier around 45% has come down to under 30%, paralleled by a culture negativity increase which is shown in red from 50% to today over 70%. And this, I think, is true for everyone all over the country. So while the Western literature would term this culture negative endophthalmitis as non-infectious or sterile, we as practicing ophthalmologists know that that is not true in our scenario. You all are diagnosing them, you all know this is infectious. So why is microbiology labeling them as culture negative? And what are these reasons? There has been no change in the practice patterns in the last 25 to 30 years. Are pathogens getting smart? Or are we really making a clinical overdiagnosis? And I don't think any of you all sitting here in this audience believe that this is true. Are we dealing with sequestered, unculturable pathogens? Probably true, but we are not sure. So obviously we need a more higher modality of diagnosis. And that is where unbiased next generation sequencing today is now playing a major role. So what has changed in the last 3 decades is the advanced microbiology techniques. Today we just can't rely on traditional microscopy and culture, and we need molecular techniques like PCR, Sanger, and NGS in our spectrum. Apart from diagnosis, in the antibiotic susceptibility patterns, also what we have seen is over the decades, gram-positive, we have some solace there. There has been only a marginal increase in resistance for vancomycin, though for gatifloxacin there has been a sharp rise in resistance. But this is not true in gram-negative. In gram-negative, our primary empirical antibiotic of ceftazidime, the resistance has increased to over 65%. And this is alarming, and we should take note of this, because we should now need an alternative to gram-negative drugs. So in view of all of this change, Dr. Das has initiated an endophthalmitis management study, which is a multi-center prospective randomized clinical trial, of which the details he will probably be doing it in the next talk. So I'm not going into the details of that, but what we did in that study is for microbiology, along with culture and microscopy, all samples in that study were processed for PCR as well as NGS, next generation sequencing also. In addition, we tried for the fungal organisms that grew in that study, we tried to also do antifungal susceptibility by macrodrop dilution method. So the gist of it is that among the 428 samples that were included in the study over the 4 years, what was available for us for culture was 408. There were some reasons for which 25 samples could not be included, and what was available for PCR were 405. What was surprising was, if you remember the initial slide where I told you gram-positive was higher compared to gram-negative, now what we see is that there's a huge rise in gram-negative organisms. Today, gram-negative is 82 and gram-positive is 42, followed by a little bit amount of fungus and gram-positive bacilli. But the organisms, however, did not change. The names of the organisms, if you see, Pseudomonas aeruginosa, Staphylococcus epidermis aureus, Bacillus, and Corynebacterium, they were more or less similar. So while the organisms and the etiology spectrum did not change, the ratio of gram-negative versus gram-positive changed dramatically among the culture-positive bacterial endophthalmitis. So when we looked at the NGS results of the culture positive, only 9 of the 200 samples did not match with culture. So with that confidence, we had the confidence to accept our NGS results and move ahead to look at the culture negative samples. So when we looked at the culture negative samples, we got the usual culprits like E. coli, Moraxella, Klebsiella, Pseudomonas, Staphylococcus. So we were surprised. Obviously, these are organisms that could have grown in culture. So probably, we being a referral center it is possible that the patients who come to us are being treated elsewhere, and that's why, hence, they are not growing in culture. So there is no reason, we are not dealing with any unusual organisms that cannot grow in culture. So culture negative also has the usual culprit of organisms. Probably load is low, or probably they're being treated and hence unable to grow in our usual detection methods. Following that, we also looked at the susceptibility pattern, and what we saw was cefazolin was, we had 100% susceptibility, followed by vancomycin, which was equally good at 97%, followed by gentamicin and moxifloxacin in the gram-positive group. So while we are good in the gram-positive group, the gram-negative was slightly alarming. What we thought that imipenem would be good was actually not. It was colistin that showed the highest susceptibility at 89%, followed by amikacin at 78%, followed by ceftazidime at 70%, and imipenem at 66%. In our cohort, we also had 36% multi-drug resistance. Now, when I say multi-drug resistance, I mean more than 3 families or classes of antibiotics. Of them, among these multi-drug resistant organisms, 81% of them were obviously gram-negative and 15% were gram-positive organisms. Among the gram-negative organisms, all of them were resistant to almost all classes of antibiotics, but colistin was slightly superior than the rest. Among the gram-positive organism, only vancomycin, actually there were only 4 isolates, of which one of them was vancomycin resistant. Now, what was also interesting is, along with gram-negative being alarming, we did find fungal also in our acute post-cataract series. So we found 6 fungal culture-positive fungus which grew, and were predominantly Aspergillus and Fusarium. But apart from that, we did find 9 culture-negative fungus also, which were predominantly, again, Aspergillus and Fusarium, though there were 1 or 2 Candida species also. So what I'm trying to emphasize here is almost 1 in 10 acute cataract, post-cataract endophthalmitis can be a fungal organism, especially when it is culture negative. So do have a suspicion of fungal also. I'll be quick. When we look at the antifungal susceptibility, however, almost all of them were resistant to all the drugs tested, especially voriconazole. When susceptible, it was only caspofungin and posaconazole that did show slight amount of susceptibility. So maybe it is also time to look at newer alternatives like caspofungin and posaconazole, whether they can be used intravitreally also. Amphotericin B did show to be slightly better than voriconazole. To summarize them, among the 428 patients that were recruited, culture positivity that we saw in our study was 31.5%, but when we included PCR and NGS, the culture positivity, the microbiology positive samples improved to 61%. So that brought us to our original 3 decades back percentage of positivity that we used to see before. So to summarize, what I would like to say is culture plus microbiology using NGS, the positivity improved to 61%. There was no susceptibility difference between ceftazidime and imipenem. Colistin proved to be superior than ceftazidime against GNB. But one point to note is that the GNB resistant to ceftazidime were susceptible to colistin. So probably we could use for GNB a combination of ceftazidime along with colistin. 1 in 10 cases of culture positive acute post-cataract endophthalmitis could be a fungal infection in our country. And finally, next generation sequencing is here to stay whether we like it or not. I have to thank my group for this entire study, without whom nothing of this would be possible. Thank you.
Joveeta, can I ask you a question?
Yes.
This is, we have now newer ways of diagnosing from culture to PCR to the NGS. Now, when we look at it from many of these cases, we, as a practitioner, we may be concerned what is the medico-legal importance of it. Now, supposing I do culture and I do not do NGS or I do not do PCR, what is the status medico-legally versus if you do everything, what happens? You know, are we supposed to, is an NGS analysis acceptable medico-legally, or culture is still the gold standard?
I think when you look at it medico-legally, it is still in the context of suspicion of an infection. Any of us do not do a test without a suspicion of an infection. So every time we always write the underlying statement is correlate clinically. So the medical legal case will have to lie with the ophthalmologist is to correlate it with the clinical scenario. Whether you accept that
I think
diagnosis.
culture, PCR and NGS cannot fall into legal framework because of not widespread availability. Because once you issue guidelines on behalf of any society or whatever, you have to make minimal possible, not the maximal or most sensitive part. If you include PCR or NGS into it, then it may create an issue also. And most of the treatment is empirical only to begin with. Only thing what I would I wanted to compliment Dr. TP and the LBP group is, you see, most of the people in the country still follow EVS, which is more than decades and decades old, 25 years back. So I think there's a need to change. There's a need to change, like you rightly highlighted, but only that colistin should be substituted to ceftazidime. The only thing is, why did you say that both can be done, colistin plus cefta?
So CLSI guidelines say that colistin is your last drug, last resort drug. So they in fact advise not to use it alone. They say that it should be used in combination with any other drug.
The reason I'm asking you,
but this is again for systemic. This is not an ocular guideline.
The reason I'm asking because I want to take guidance from sir also, that because we are in the process, for a long time back, we have been issuing, the charts from CIPLA and other companies for the mass dissemination. So yesterday only I visited that place and there was a need to revise these guidelines. So I'll ask and take guidance from sir, should we now say Vanco colistin as first line if you are gram negative, or as second line?
No, I agree with you, Lalit. But in answering question of Ajay first, that currently still culture is the gold standard, even though it is lowered down, 30–40% only are culture positive. The reason is that they are the only time you can do a susceptibility testing. PCR, you can't do a susceptibility testing. NGS you can do, but NGS does the ARG, antibiotic resistant gene, not susceptible gene. So I will still say culture is required, but someday it will change to NGS, even skip PCR actually. Coming to question number 2, whether it should combine or not combine, or shift or alternate to ceftazidime. I know that most of the people working in Delhi do not give ceftazidime anymore. It is mostly either imipenem or piperacillin tazobactam. And Joveeta's contention is that what he told for last drug, I will anyways talk about that in my presentation next, for systemic, not for intraocular. Systemic colistin is 9 million per day. And what to give colistin inside the eye is 1,000 unit intravenous units one time. That is 1/9,000th of required drug systemically, and 2, half-life of colistin only few hours, 3.5–4 hours. So how will it go actually enter the systemic circulation to cause resistance? But that is debatable. Just because somebody said, I will not believe it. Also, to this audience, I will remind you that all of us give ceftazidime as a drug of choice for intravitreal first choice. It was not tried. When we talked evidence-based medicine, EVS tried on amikacin as a drug with along vancomycin, but changed to ceftazidime because amikacin is found to be a macula toxic, retina toxic. But nobody has questioned this, that did you try ceftazidime? I'm not questioning the wisdom, but then certainly say that is not the last wisdom all the same time. So I think I'm happy that my team helped me to do this last study, and then hopefully VRSI, AIOS, everything will rewrite the guideline to what is applicable to us or to South Asia compared to what is applicable to Caucasian population.
So my question still remains unanswered. What should be the first empirical choice?
We have changed actually. We have changed, but then unless you do another experimental study or animal study, you can't say.
You have changed to?
We have changed to cholesterol or imipenem, etc.
Venco plus.
Plus, yeah. Venco still remains very good.
Venco remains supreme.
Incidentally, Venco is also last drug to be used for gram-positive cocci infection. We'll just quickly